Hi, everybody. Welcome to the care of the client with respiratory disorders. Human survival depends on the ability of oxygen to reach the body's cells and of carbon dioxide to be removed from the cells. Respiration is the mechanism that the body uses to exchange gases between the atmosphere, so the air outside of us in our environment, and the blood, and between the blood and the cells. The most important factor is the level of carbon dioxide in the arterial blood. An elevation in carbon dioxide causes the respiratory control system in the brain to increase the rate and depth of breathing. So with normal breathing, a regular interval occurs after each respiratory cycle. So we got a regular inhale, exhale, normal depth, and normal rate of breathing. But when a patient presents with a disorder to the respiratory system, this mechanism is compromised. You need to recognize these problems as the nurse. So as we get into learning about the respiratory system, the disorders with our patients, a thorough assessment is obviously required, and gathering a health history is so important. So think about some questions that you would ask when you are admitting a patient with respiratory disorders and all the investigation that comes around or is involved with admitting a patient or has been admitted and you received into your care that you can do further investigations or in asking questions that maybe that patient wouldn't have given to you, the previous nurse. So you start off with saying, what made you come in today? You know, maybe they reply with shortness of breath. Can you tell me more about the shortness of breath? Is there anything, you're going to go through your whole cold spa of what makes it better or worse? Or you need to ask, where do you work? Is it an environmental thing? Um, so once you figure out why they've sought care, maybe they have said, because I'm short of breath, then you're going to ask, what kind of health history do they have? Do you smoke is an important question. What environmental situations are you exposed to? Are they allergens that are triggering the shortness of breath? Do they have a cough? Do they bring up sputum? What does the sputum look like? Another really, really important question is, do they have chest pain? And if they say yes, then you have to determine what kind of chest pain that is. Is it a chest pain related to cardiac, or is it a chest pain related to maybe they've had a cough for days and they've strained muscles in their chest causing that chest pain? So you have to do some really good critical thinking, come up with some good answers, and like I have always said, never, never rule out chest pain. So yeah, you want to do a really good family history. Maybe is it something that is genetic that is coming up? Maybe is there a history of COPD in the family? Anything that may be genetic related. You want to do a really good review of the system, doing a really good thorough assessment, which is required right from the mouth, nose to the lower lungs, right? Respiratory starts at our nose and mouth and then goes all the way down to those lower lobes. So we want to review medications as well, and yeah, ask all those appropriate questions that go along with a health history. So, and again, we're going to touch on the age-related changes in our aging population. Some elderly people have a chronically watery nose, and that just might be a chronic situation. Maybe it's due to positioning. We see some elderly folks hanging their head all the time, which causes a postnasal drip. Maybe they've got or they end up with thinner mucous membranes that produces less mucus that gives them a dry mouth, a dry nose. In the event of a dry nose, they end up with nosebleeds. Maybe it's a medication-related issue. As we age, we get a decline in the sense of smell. Tissues in the larynx are drier and less elastic in older adults, therefore causing complications for breathing. Also swallowing difficulties. So a weakened esophageal sphincter, also causing gastric contents to backflow, and obviously worse when they lay down, as we learned about in the GI system. So the diagnostic tests around our respiratory system. You learned in skills testing that we've got our throat cultures and nasopharyngeal throat swab or nose swabs that happen when we're testing for maybe CNS or maybe strep throat, COVID, influenza A, whatever that may be. We do laryngeo, or we don't, respiratory doctors do laryngeoscopes and bronchoscopies. This is where they stick a tube down your mouth into, depending on where they're going to biopsy, in your lungs, and they take a sample from maybe they're concerned about a tumor there and get a biopsy from that. We do x-rays, CTs, MRIs, and another thing that nurses can do and is done in doctor's offices as well is pulmonary function tests, which are non-invasive tests that show how well the lungs are working. And what it's doing is measuring the lung volume, capacity, and rates of flow and gas exchange. And what you do is you blow really, really hard into this tube, this long tube, and it does all this kind of cool measuring of when you exhale and figures out what kind of lung volume you have, like the capacity that you have with your lungs. And then we do obviously our pulse oximeter, and we're going to do some sputum analysis to measure the bacteria or possibly malignant cells in the sputum. So in an acute respiratory disorder, remembering the difference between acute and chronic, but with acute, obviously we remember that these develop suddenly and typically resolve with treatment. Some key characteristics of an acute situation is obviously that rapid onset, often caused by infections, trauma, or allergen exposure. So for example, maybe we have our asthmatics that have been exposed to triggers outside in mowing the lawn or taking a walk, and there's some kind of trigger in the environment that causes them to have an acute asthma attack. So with our acute respiratory disorders, they're usually short duration, days to weeks, and usually reversible with prompt treatment. So examples of some acute respiratory disorders are our pneumonias, and our pneumonias and are sometimes anybody that is admitted with an acute bronchitis or an upper respiratory infection, depending on what it is, they are put on isolation. So they're admitted into a private room where they're isolated and a contact droplet precaution sign goes up because whatever they have is infectious, and we want to protect ourselves from that. Also, we can get an acute disorder of a pulmonary embolism. And that is developed through clot formation that ends up dislodging and lodging in our lungs and causing a sudden shortness of breath, chest pain, hypoxia. So typically we see that from immobile patients when they come in. They're sick, they're not moving well, post-operative patients. So this is where our nursing interventions come in, where it's so important to mobilize while in the hospital. And then medication-wise, these guys are put on what's called a prophylactic anticoagulation. So our Lovenox, our tinzaparin, and these medications are anticoagulations that are given to prevent these clot formations. So with our chronic respiratory disorders, we're going to touch on some asthma and our chronic bronchitis and our emphysema, our COPDers, and our bronchiectasis. So I'm sure everybody's heard about asthma. We've talked about it a little bit, and that's is characterized by a chronic airway inflammation. And there are several types of asthma that differ in clinical features and treatment responses. And depending on what kind of triggers initiate the asthma, it can be anywhere from just a chronic situation, but can also lead to an acute exacerbation. So we just want to make sure that we're familiar with asthma people, what they need, what they require as far as treatment goes, and when they are bad enough that they come in. It's not too often that we get asthmatics admitted, but typically we're doing, in the event that it is a serious case, we may have to do some oxygen supplements. Maybe they need an antibiotic. Maybe they need some puffers. And some signs and symptoms around that, I guess, within the with our acute leading to chronic, or sorry, chronic leading to acute in an exacerbation, we see some dyspnea. They're going to have a chronic cough, using accessory muscle uses when they are trying to breathe, and that's where it gets to a point where we're looking at admission and just need a little bit of help to get better. So then with our COPDers, also known as chronic obstructive pulmonary disease, it's described by a condition marked by progressive, largely irreversible airflow obstruction. So the peripheral airways become obstructed and inflamed, trapping air during expiration. The elastic tissue in the small airway becomes damaged so that the elastic recoil is lost, contributing to air trapping. And trapping leads to the expansion of the chest so that it becomes like a barrel-shaped. And once you see a barrel-shaped chest, you'll know exactly what I'm talking about. But I did post some videos around. It's a great video, Understanding COPD, and the barrel-chestedness with our bronchitis, and then the emphysema, and then the other chronic condition being bronchitis. So early stages with our COPD include chronic inflammation of the respiratory bronchioles, alveoli, and pulmonary blood vessels. Patient will develop a chronic cough, more extreme inflammation and damage than with a person who does not have COPD because the normal defense mechanisms and repair processes are disturbed. So this is where it comes in that the irreversible airflow obstruction can't be fixed. And then our late stages, what we would call an end stage COPD person, will begin to affect the heart muscles due to decreased oxygen, hypoxic changes in the small coronary arteries. So how they get diagnosed with COPD is the pulmonary function test that I explained. It measures the total lung capacity and the expiratory volume on expiration, so when breathing out. So COPDers who are chronic usually end up on oxygen supplementation. They're on a bunch of different medications, specifically puffers to help with their airway. And then we talk about chronic bronchitis. When the increased production of mucus and chronic cough persists for at least 3 months of the year for 2 consecutive years. So there is a, like the Lung Association puts rules and what kind of criteria you have to meet to become a chronic bronchitis person. So there are, so when a person has COPD, they could have the chronic bronchitis or they could have the emphysema. So with the emphysema, they have difficulty breathing because of the damaged alveoli, which result in the loss of elasticity and loss of surfactant, causing that air trapping. And our emphysema folks, you're going to see breathing, which is called pursed lip breathing, and again, have that barrel chestedness. We're going to see some tripoding happen, trying to open up that airway to help with that gas exchange due to the barrel chest. Now, with people with bronchitis, they have more of a belly, and it explains it really well on the video I posted. And we're going to see more of bronchial tubes become permanently damaged and enlarged, increase in bacteria and mucus. So our chronic bronchitises have more mucus and a cough, and suffer that way through their COPD. And so this is where they have trouble breathing because the abdomen becomes so big and it pushes on the diaphragm up into the lungs, causing problems to breathe. So we're gonna, as you can, hopefully you've watched the video. If not, it gives wonderful explanations of pursed lip breathing and our huff coughing. And we get into that a little bit more in the slides as well when we talk about some other kind of interventions that we can do. So then we talk about the lung cancer. Lung cancer can happen anywhere within our respiratory system. As we talked about, we can have oral cancer, we can have esophageal cancer, and we can have lung cancer. And it can be a primary cancer or it can be secondary that metastasized from somewhere else. So you're going to do a good health history, find out their physical history, family history, and yeah, we're going to find out what kind of clinical manifestations that the patient has maybe come in with that is causing them to be admitted, and doing investigations to look in to see if they end up with lung cancer. So maybe these guys are, and which is a high contributing factor, is being a smoker. So that's one of your first questions you're going to ask. And maybe they've had a persistent cough that doesn't go away. Maybe they're having, when they're coughing up blood, or what's called hemoptysis. having chest pain, and maybe recurrent pneumonia or a bronchitis that just keeps kind of going on and going on. They go to see the doctor, they get antibiotics, it doesn't help, and it reoccurs. So there's going to be flags that end up triggering the doctor to maybe do some further investigations around this. The patients might have dyspnea, weight loss, pain in the shoulder, arm, or hand, and of course, other signs and symptoms that may be related to metastatic lesions. Maybe, I don't know, maybe they started out with prostate cancer and now they're concerned that maybe it has metastasized into the lungs. So, depending on the stage at which the cancer has been found, maybe it's idiopathic. Remember, we've talked about idiopathic, no signs and symptoms. Maybe all of a sudden they have symptoms and maybe it's at a later stage, or maybe it has been caught on time that they can do some diagnostic treatment. They would do a bronchoscopy, stick a tube down their throat, get a sample of that tumor on the lung and stage it to see can they surgically remove it? Do they end up with what's called a lobectomy, where part of the lobe is taken away from where the tumor is? Or do they need to go right into some chemoradiation, or is it past the point of that no treatment can be performed? So, what are some factors that could lead to alterations in the respiratory function? So we've talked a lot about hypoxia, um, introducing to you altered breathing patterns and obstructive airway. And we're going to get into that more in the slides to come. So for hypoxia, we know that the definition is not enough oxygen for the tissues. There is a deficiency in the delivery or use of oxygen at the cellular level. We can have hypoventilation, which causes hypoxia, which is a decreased rate and depth of respirations. We can have hypercapnia, which is an increase in CO2 or carbon dioxide in the blood. So for example, maybe somebody who has pneumonia, the edema and secretions that occur can interfere with gas exchange, resulting in inability to expel the CO2. So that's going to end up causing hypercapnia. And then hypoxemia, which is decreased oxygen in the blood. Okay, so hypoxia is low oxygen being perfused to the tissue. Hypoxemia is low levels of oxygen in the blood. So there's a difference. Hypoxia is perfusion to the tissues, and hypoxemia is low levels of oxygen in the blood. Okay? So when we look at hypoxia, we've got some signs and symptoms that we've talked about a fair amount, but we'll review them. We're going to have a rapid pulse when we're doing a vital signs assessment. We're going to see or observe some rapid shallow respirations and dyspnea. There's going to be some increased restlessness or lightheadedness due to the poor oxygen perfusion, and the low level of oxygen in our blood causes the restlessness. You may observe or see some flaring of the nostrils, and that's another way to compensate trying to get more air in. We may see some substernal or intercostal retractions or indrawing. So that is where you will see kind of like shoulders pulling forward and seeing your substernal or intercostal areas retracting or pulling in or indrawing. And that's somebody really, really struggling to just trying to really deeply draw in some air. And then our cyanosis, our bluish discoloration of lips, nail beds, mucous membranes due to decreased oxygen saturation in the blood. So here is where we define what our altered breathing patterns are. And I'm sure, hopefully, however, I don't know if Rayanne's gone through the respiratory system with you guys for assessment, but we're going to review them real quick here. We've got what's called eupnea, which is defined by normal respirations. So this is when you're just sitting, relaxing, you're having normal respiration on our normal range scale, anywhere from our 12 to 20 respirations per minute. Okay, so our tachypnea, we're going to have rapid respirations. And that could be caused by maybe a fever, maybe your patient's in pain, or maybe they're having some anxiety. So that is easily observed and requires intervention or investigation into what is going on and the intervention that needs to follow that. The same with our bradypnea, so our abnormally slow respirations. And this could be caused by maybe sedatives given, like our Ativans, our maybe mental health related, maybe they require some Valium, something like that. So those are our sedatives. Then our opioids, maybe our patient's post-operative, and we've given them way too much pain medication, and now their respirations have become slow. And policy in Alberta Health Services that you'll encounter when you go into clinical, you will, when you're assessing respirations, if you know that your patient has been given a sedative or opioids or something that has slowed their respiration rate, anything below 10, but for sure 8, ends up Narcan. So that's what happens from us overdosing them, our alcoholics. And then we see bradypnea from metabolic and respiratory disorders as well. And then we have what's called apnea. So A is absence of, remember that, cessation of respirations. So in the video for breathing patterns, it explains and shows you, it has a good video on what apnea is. But so cessation of respirations, no air movement for periods of time. Like we see this sometimes with our palliative patients that are beginning to pass away. We have people who have sleep apnea, where they might take a deep breath. Maybe it's kind of like holding your breath and they don't breathe for a certain length of time, and then all of a sudden they do. So that's apnea. And with apnea, maybe if it is a sleep apnea situation where it only occurs when they're sleeping, patients can get what's called a sleep apnea machine. And when they sleep, they require either wearing a mask or nasal cannula, nose pieces into their air that provide oxygen for them while they sleep, because they hold their breath so much that they become bradypnea and decrease SpO2 levels. So other types of breathing patterns, we've got our hyperventilation, where increased movement of air into and out of the lungs. It's abnormally fast and deep breathing, low carbon dioxide occurs, which makes blood vessels constrict, causing lightheadedness. And then we've got our hypo or low ventilations, inadequate alveolar ventilation. And this is reduced movement of air into the alveoli. And this is where we see low oxygen levels and high CO2 in the blood. And this is caused by they're holding their breath for too long, which causes a retention or to retain CO2 and can lead to confusion and dizziness and lightheadedness, all that kind of stuff as well. And this is where we really utilize that pursed lip breathing. We want them to take a deep breath and really, really blow out slowly to cause that air exchange to get rid of that the CO2 to blow off and get a proper balance of our oxygen and CO2 to happen. And our dyspnea is difficulty breathing or shortness of breath on exertion. And our orthopnea, inability to breathe except in an upright or standing position. They're more so short of breath when laying flat, so they require to be in an upright position. And a lot of times these guys that are orthopnic have to sleep in a recliner or with lots of pillows behind them to help with breathing when they're trying to sleep or in any situation really. And we're going to do our best to provide comfort for them. We're not going to put the head of their bed low and expect them to try and breathe when they have an inability to when only upright. So we're going to make sure we provide comfort measures for our folks. So cardiovascular alterations. So we have cardiovascular functions that can be altered by conditions of our respiratory disorders. Some being, so when your lungs aren't working well, it can put stress on your heart and blood flow by cardiac output. So our cardiac output is compromised, and the heart may be struggling to pump enough blood if it's not getting enough oxygen. Then we'll also see poor tissue perfusion. So this is when the heart has to work harder to get oxygen-rich blood to the body's organs and tissues. So this is where we see a poor capillary refill, cyanosis happening, and then blood changes. So if the blood can't carry enough oxygen or remove carbon dioxide properly, it affects how well your body functions. So you may see the tachypnea, cyanosis, bradycardia, slow capillary refill as well. Yeah, so I just popped this slide in just to warn you and remind you of the activity that I posted that you're going to be looking for special images, these listed, and pay particular attention to slide 16. So just a bit of a review. Which of the following is an age-related change in older patients? So hopefully you picked out B, or epistaxis nosebleed is more common in older adults due to thin mucosa lining. Maybe they're on anticoagulations, which slow up the blood clotting, and we're going to see more nosebleeds happen. So treatment for respiratory illness, um, we are going to um, treat them with deep breathing and coughing. We're going to provide hydration, medications, incentive spirometer, percussion, vibration, and postural drainage, and oxygen therapy. And these next slides, we're going to go into them. Labs associated with the respiratory system include our what's called our arterial blood gases, and you'll hear nurses call them ABGs. And I briefly spoke about these, this kind of a lab in previous theory or maybe patho, I can't remember. And this is where a respiratory person, respirologist comes in and they use that special needle instrument and they draw blood gases from the artery. And this is where we get a real definitive answer on what kind of metabolic or respiratory acidosis, alkalosis that we're dealing with. There's also our CBCs, which is our standard white blood cells, neutrophils, all that good stuff. Sputum culture and sensitivities. D-dimers, these are our deep vein thrombosis, and as I kind of talked about with the pulmonary embolism, these develop in anywhere in our body actually, and can dislodge and lodge into our lungs and cause a pulmonary embolism. We do blood cultures as well when somebody comes in really sick with a respiratory infection. And then our procalcitonin or our C-reactive protein, or what is called our CRP. And these are our markers for infection and or bacterial infection and an inflammatory process going on. So deep breathing and coughing is an important nursing intervention that you need to learn about. And it's an important intervention because we don't require a doctor's order for it. However, that being said, the doctor may order it specifically to make sure that you are going to do it. So what deep breathing and coughing does is it helps loosen and remove secretions. So when we talk about deep breathing means going all the way down to the abdomen. Breathing from the abdomen permits full deep breaths with little effort. And I believe the video that I posted goes through that really good, and it's a good way to help educate your patients and help them. You can get a pillow, put it on their tummy, and really teach them about how to go right down into the abdomen, taking those full deep breaths, and then coughing as they exhale, and that's going to help with good gas exchange and getting that mucus or whatever maybe is stuck deep, get it moving as well. But specifically getting those lungs woken up again. Maybe post-surgically, their lungs are too lazy and haven't woken up. Maybe they haven't mobilized enough. And then the pursed lip breathing helps the clients create resistance to outflow of air. Prolonged exhalation or breathing out prevents airway collapse by maintaining positive airway pressure. And I like to use this, and you'll see chronic COPDers pursed lip breathe a lot. And that's what they're trying to attempt, is just taking the long exhalation, and they're trying to breathe, and it's causing that breathe off of the CO2 retention. And when I have people come back from surgery and they are in a pain crisis and they end up hyperventilating, I try to really get them to, I get their full attention. I think I've explained this before. I want you to focus on me and watch what I'm doing. And I want you to take a really deep breath, and I want you to purse your lips like you're blowing out a candle, and slow, slow, slow exhale, just really, really slow. And you have to really talk to them to help them focus on you and demonstrate as well. And before you know it, they're really focused, and they've got that tachypnea and that hyperventilation slowed right down where they're maintaining a normal respiration rate. And then the huff coughing is more effective than a forceful cough. Instead of just like, if you're doing some deep breathing and just coughing out, this huff coughing, which is also in the video, I'm not going to do it over a voiceover, but the video has a good explanation on that. So as a med-surg nurse, deep breathing and coughing becomes a common nursing intervention that aids in the prevention of possible pneumonia. Like I said, pneumonia loves to breed, that bacteria loves to breed in warm, dark, wet places. And when you come post-operatively or are sick and not mobilizing well, and those lungs aren't doing the job that they're supposed to, this is a prime breeding ground for pneumonia, and this is where we want to utilize this deep breathing and coughing. And also helps with that gas exchange and get the oxygen moving and better perfusion and better blood exchange, like the blood changes where we're going to see more oxygen carried throughout our blood and better oxygen levels that way as well. And also, believe it or not, that deep breathing and coughing also helps with prevention of fever or resolving a fever. So again, it's moving that mucus that might be trapping in our lower lungs, getting that air exchange happening, and working on that fever that the patient may end up with as well. I've seen it happen. So lots of like nursing interventions that we can do for prevention or to help correct our folks that are having complications. So then we get into hydration. And of course, we want to provide adequate fluid intake for our folks, whether it be oral hydration, IV hydration, or maybe humidification of room air. Maybe a humidifier has to go on, and as well as the use of nebulizers to promote adequate hydration. Nebulizers specifically deep into our lungs, where we run a nebulizer and they breathe us in, and it gets right down to the lungs to get some hydration. We're not seeing so much of nebulizers and humidification since COVID, but last time I worked, a couple days before I got hurt, we were actually running a morphine nebulizer on this little old lady. She was having trouble breathing, and morphine nebulizers assist with that. And then when I was in the hospital, I was roommates with a guy that was actually had a humidified oxygen going on. And it's not so common anymore because the water molecules become larger and can spread around microorganisms, and we don't want that. So we want to maintain moisture of the respiratory secretions. Like I said, those nebulizers and the adequate fluid will help reach down into our respiratory tract. But in the event that we don't, we may have these secretions become thick and tenacious, meaning really sticky. Also with hydration, so maybe, and we'll talk about it a little bit more in Skills Lab, we patients can go on what's called Optiflow, and Optiflow is really high concentration of medical air and high flow, and it's coming at them so forcefully that it can dry them out so bad that the air gets humidified. And so when that happens, there's lots of dampness around their mask or their cannula, which can cause some chafing and skin irritation. So we want to be mindful and careful of that. Medications that are used to help with respiratory disorders. We've got our bronchodilators, and those are administered to open up help our folks open up their airway. We've got cough suppressants that we give to suppress a cough. Maybe they're admitted for like an influenza A or something where they cough and cough and cough and cough and cough, and like they just can't catch their breath, or they're coughing so much they're vomiting. So we can give them stuff that will suppress that cough. But then we can also give them something that will help them get rid of all of that mucus. So we can give what's called an expectorant. And this increases and thins respiratory secretions for easier way for them to bring them up and spit them out. And then, of course, our antibiotics. Here we have, as previously mentioned, our incentive spirometer, which you might hear nurses refer to as an IS. So I for incentive and S for spirometry. And this is the cheap little tool, but is mighty in what its intervention will help with our lungs. And so what it does is maintain or improve pulmonary ventilation. So we're helping with our inhalation and exhalation, in and out breathing. It counteracts the effects of anesthesia, so it helps blow off anesthetic when patients return from surgery, or helps with hypoventilation. It helps loosen respiratory secretions, and it facilitates respiratory gas exchange because when they're utilizing this thing, it is mimicking breathing in and out and getting our lungs working. So it'll help expand collapsed alveoli and measures the flow of air inhaled through the mouthpiece. So what that means is you can see in the picture the long blue tube, and at the end is the mouthpiece. And we're going to go through this in lab, but they put their mouth on this mouthpiece. And what they do is they suck on this. They don't blow out, and they require teaching for this little machine. And what they do is they suck in, and what happens is a little ball will come up, and so you'll see the yellow apparatus there with all the lines. And so you can increase the difficulty of this. And so obviously you want to start out easy for them, but as they improve, you want to make it harder so that we can get those lungs working. And so this kind of is like a care plan or a plan of care that you can do with your patient, because we want them to be involved in this, but we can give them little ideas. And what I do with my patients is I get them to set an alarm that maybe every hour it kind of alerts them to practice their IS. Maybe you can say every time there's a commercial on, maybe you can do this. Or whenever you wake up, even in the middle of the night, to do it. And so It's an important guy that's going to keep away those pneumonias, keep away the atelectasis, keep away the hypoxia. And there's also a video posted of how to actually use this. And then this is where we see percussion, vibration, and postural drainage come into play. And again, if you've done respiratory assessment with Rayanne, she's probably did some teaching around this too. So it's dependent nursing functions performed according to the physician's order and agency policy. So you need to know as an LPN what you can and cannot do with percussion, vibration, and postural drainage. So if you're lucky enough to work in a big hospital, we use our respiratory therapy department as a resource to do this for our folks. But maybe you're working in a rural hospital where you're the respiratory therapist along with everything else. You do need to know how this is performed. So postural drainage and chest percussion is going to help in removing the secretions from the lungs so that the patient may cough them up and so that they may be removed by suction in the event that that's what's required. So in another slide, I'll show you what postural drainage is, but percussion, you're going to clapping cupped hands against the chest wall to loosen secretions of your patient. And they go into a position, obviously, that's comfortable for them. And I do believe the next slide kind of shows it a little bit more detail. And then vibration, you're using some vigorous movements produced by the hands to help loosen secretions as well. So this is a percussion where you see the picture of the cupped hands, and you're going to gently, or for whatever your patient can tolerate, kind of, I say pound on their chest or on their back or whatever they can tolerate, but pound to a toleration, like what they can tolerate. And so again, we're trying to help loosen up the secretions. And then your postural drainage, this is what this looks like. We've seen some of this with COVID, when respiratory, we helped a lot with these guys, trying to get rid of the mucus and secretions that developed as a side effect of COVID. And what it does is it just, like the position that your body is in, helps or aids in draining the mucus to help aid in getting it to come out better. Then we talk about oxygen therapy. And again, we go into a lot more skills in lab in a couple of weeks, but we're going to just kind of touch on some of the knowledge around oxygen therapy. So there are several ways that oxygen can be delivered to the tissues. Oxygen is mixed with room air before being delivered. Concentration of room air in mixture can be adjusted for needs. Method used will depend on the client's needs, the comfort, developmental considerations, agency policies, and whatever the doctors have ordered. So hospitals have bulk oxygen systems with wall adapters and flow meters that are attached. And I'll show you, there's some pictures coming up here. And the regulator with a flow meter must be used in a hospital setting. So oxygen therapy is ordered in liters per minute or fraction of inspired oxygen, or what is initialized by an FiO2. This measurement is written, for example, as 0.30 FiO2, which means 30% oxygen concentration. So we mostly see this happen when our folks with what's called Optiflow is on, and you might see the respiratory right in their notes. Like I think it's like 60% at 100 or 10 liters. So it's whatever fraction of inspired oxygen is being delivered, plus at what rate it's being delivered. So on that flow meter. So flow rates from the flow meter may be adjusted from a minimum to a maximum and measured in liters per minute. When patients with oxygen must be transported, a cylinder on wheels is necessary. You will learn more about this in lab and upcoming pictures. I've got some pictures of this. So yeah. So indications for oxygen. Clients who have difficulty ventilating all areas of their lungs, those whose gas exchange is impaired, or people with heart failure may require oxygen therapy to treat or prevent hypoxia. So this is where our assessment skills come in that are really important, whether it's as soon as you enter the room and your observation skills pick up on somebody being hypoxic or cyanotic, cyanotic, tripoding, struggling to breathe, using accessory muscles to help them breathe, looking anxious, and you right away start using your critical thinking. Can you tell me what's going on with you? Yes, if they're short of breath or having difficulty breathing, you're going to take vital signs immediately. So that being said, we never deprive. So oxygen, as we learned, is a doctor's order, but we never deprive somebody of oxygen to stop to get a doctor's order. It is, we always, like I said, deal with our ABCs. We want to provide oxygen, help a person breathe, get them stable, and then deal with phoning the doctor. So it's important to know that yes, oxygen needs a prescription, but our nursing interventions allow us to apply oxygen without it and getting that order later. So it's important to know that we need to use extreme caution with people with COPD, and docs usually write an order for what they want oxygen levels to maintain at with people with COPD. They usually hover around 88% on whatever liters per minute that they come in with, and we keep it at that. We have to understand the importance around people with COPD, that they're used to having low levels of oxygen and high levels of CO2. So if the body gets too much oxygen, the drive to breathe is lost. So if they already have, if the body gets too much oxygen and they're already on maintaining whatever, that 88% or 90%, and we think, oh, well, that's not a normal level, we've got to give them more oxygen, we're doing harm to them. Okay, so we have to understand the process of the importance of understanding COPD people when they come in and recognizing. And this is typically why doctors will automatically prescribe maintain oxygen levels between 88 and 90 and not going over that or under. I think that's it for this slide. Let's go on. So when we assess oxygenation needs, we do a good assessment as far as gathering a history, doing our physical examination, utilizing that pulse oximetry for monitoring what their oxygen levels are. We may have to do some cardiac monitoring and review relevant diagnostic data. So that being said, we need to be familiar with our oxygen delivery systems. So we do, up in the picture A, we have what's called a nasal cannula. And these nasal cannulas are specific for our nose. Excuse me. You'll see the two little prongs sticking out, and that's what goes into the nose. And we're going to go into this, and it's a little bit difficult on a voiceover PowerPoint to point out, but those two little prongs go in the nose and they go in a certain way. And if they're put in upside down, the oxygen will just blow to the top of their nares and they're not going to get adequate oxygen supply. Now, if you'll notice, this oxygen tubing has got a green tinge to it. So there are two types of nasal cannula. There is one that is specifically clear, and that's a standard normal nasal cannula. And this green tinge is more of what we call a high flow nasal cannula. And it's just the difference of it is the tubing is open more. So when the difference at the time that we would use a high flow nasal cannula is when we're needing, so nasal cannulas, oxygen delivery runs anywhere from 1 to 6 liters max per minute. And maybe we need to use a bigger tubing to help get that oxygen delivery through. And this is how in the event. So sometimes our basic nasal cannula tubing just isn't cutting it. So then we go for this high flow nasal cannula, and it seems to deliver the oxygen to the patient better. Then we've got some face masks, and they categorize in a high flow, which might be our Venturi mask, which is in picture C, a large volume nebulizer that isn't pictured here. We also got low flow delivery, which is our simple masks, and our non-rebreather and our rebreathers. And then we've got face tents and all kinds of different kind of systems. And depending on the delivery, so the liters per minute that we deliver oxygen at is what you choose to utilize on that patient. And we go into it in a lot more detail in lab. So the good thing with nasal cannulas, or the prongs, is they're easy to apply and do not interfere with a client's ability to eat or talk. The delivery is low concentration of oxygen at a flow rate of 1 to 6. Useful when client only needs low flow and less confining. So, but maybe in the event that they're a really sick patient and they require more oxygen. So we've reached our max when we've given oxygen at 6 liters per minute, and we do an SpO2 and we see they're still not maintaining their oxygen level how they should be, then we have to step it up. So that means that we end up going to our other delivery systems. So we've got our face masks. And all face masks other than a Venturi mask should run at no less than 5 liters a minute. So maybe our patient is too hypoxic with the 6 liters per minute on nasal cannula. We know that they're not maintaining a good oxygen level. We need to step it up. We reach for an oxygen mask. Doesn't matter. It can be a simple mask. It can be a partial rebreather, depending on the amount of oxygen that's going to be delivered. And we usually we kind of start low, go slow. So we go from nasal cannula to the simple mask. So maybe we have to crank that oxygen up to 8 liters. Yay, we've saved their lives. We've got some good perfusion happen. And we can start titrating them down, which means start taking them down off of that 8 liters per minute. We slowly turn the oxygen down. We're monitoring them, always checking their SpO2 level. Oh, yay, we've got down to 6 liters a minute. At that point, we can switch them to the nasal cannula. Mostly because, well, I mean, for one, it delivers oxygen too high of a rate, but also now when we give them the nasal cannula, it offers better, um, like it doesn't interfere with the ability to eat or talk, less confining. A lot of people don't like the mask. They get quite claustrophobic with it. And then we've got our partial rebreathers and our Venturi mass and our non-rebreathers, which is our highest oxygen concentration. So in your textbook, you can read up on that specifically. It goes into a little bit more detail around the liters per minute, the advantages and disadvantages of what you are using. And it's good to read up on this and become familiar so that you have an idea what we're talking about in lab. Oh, so I guess they talk a little bit more. Our simple mask, which is a delivery system of 6 to 12 liters per minute. And this mask goes over the nose. You can see the silver piece that you pinch, and you want to have a nice secure fit so that oxygen isn't being lost through the top of their nose. But then you can see holes on the side of the mask there where CO2, when they breathe out, will be released. And the green string gets put around their head to help hold it on there so somebody's not having to sit and hold that mask on their face. So here you can see the rebreather, our higher concentration, just a rebreather, and oxygen fills up in the reservoir or this bag, and can also has holes on the side, so it allows faster access to oxygen, but also when they breathe out, they're breathing out the CO2 on the side there too. And then our non-rebreather has one-way valve on the mask to prevent expired air from flowing back into the bag. So there's a little tiny bit of a difference between our rebreather and our non-rebreather. And again, we're going to go through that in skills. Venturi mask, it's got a little, you can attach little different colors to help with the delivery of the oxygen. Honestly, I've never used these, never seen them. I don't think Medicine Hat uses them, maybe in ICU, I'm not sure, but and then this face tent as well. I think they probably use these for people who are claustrophobic that can't handle having a mask on. But again, rarely ever see these. And then our oxygen equipment. So a couple slides ago, it talked about the portable tanks, and this is what a cart looks like that you put an oxygen tank on. So your patient can pull it around with you, or maybe you're mobilizing your patient and you're putting this tank on wheels so that you can pull it around. And then we've got wall oxygen, and that's common in our hospitals, maybe in I don't really think in long-term care facilities they have oxygen. They have more of those big tanks of concentrators that get plugged in. And then you'll see what's called regulators, and it's what we call a flow meter. And in the lower picture, you can see where that yellow dial is, and then the long tubey part, that's our flow meter. And so this is for wall oxygen. And when you turn that orange dial, or sorry, black dial, a ball will come up. And so once that oxygen is put in or opened up, this ball will indicate 1, 2, 3, 4, 5. It goes all the way up to 15. And so you know that your patient needs to be on 3 liters of oxygen. You're turning that dial until the ball reaches number 3. And that's where you're keeping it to deliver the 3 liters per minute or per hour. And then the bottom part, that little canister at the bottom is, or not per hour. I'm like, oh yeah, I'm questioning what I'm talking about. I'm talking too much, I feel like. Yeah, delivered 3 liters per hour. So the bottom canister, we used to, back in the day, humidify our oxygen. So water was put in that and it bubbled up through and helped humidify the oxygen for them, but we don't use these anymore. And then the other regulator sitting beside it, that's just kind of a different looking flow meter. These in our hospital, I've never seen these. I see more of the long tubed kind of regulator. And then our well-known pulse oximeter. As I talked about, it's so important to know our equipment that we're working with. And in Skills Lab, this is where you gain knowledge in that, and then as well as putting to practice in clinical. But before we send you out, we really need you to know what you're dealing with. So oxygen devices will be attached to the wall or to a tank when mobilizing. In homes or nursing homes, they are attached to what's called a concentrator, and you've probably seen some of those when you were in clinical in 158. So I just wanted to point out, and this is part of one of your activities, is in picture 1, this is the end of the tubing that will connect to, in picture 2, I'll kind of go into that a little bit more, but this is our nasal cannula, the nasal prongs, but this end of the tube is what goes on to picture 2 of our flow meter. So in our previous slide, I talked about the long shaped and how you can't really see, but obviously we'll go through that in Skills Lab and you'll get a real good visual. But this is what we call a flow meter. And you'll see at the bottom that green thing, and I zoomed in, picture 3 is zoomed in, and this is what's referred to, nurses call our Christmas tree for valid reasons. It looks like a Christmas tree. And you need this screwed on. It screws on the end of that flow meter, and the end of that tubing you push up and it connects into this. And then when you turn it on, this is where the oxygen is delivered through the tubing to the patient. So safety precautions with oxygen. You cannot smoke when you have oxygen on or you're going to blow yourself up. So usually in long-term care facilities, we see the cautionary signs. Obviously, there's no smoking allowed in the buildings anymore, so less hazard for blowing anything up in the hospital, but we do have some non-compliant patients that try. And so we do a lot of education that we have to let them know that oxygen and smoking together is combustible and we will blow things up if we do smoke. And so just doing some teaching, so people who do smoke and have oxygen will go outside, take their oxygen off, have their smoke, and then put their oxygen back on. So more safety precautions when dealing with oxygen tanks, or cylinders they're called, need to be handled and stored with extreme caution. Need to be away from high traffic areas. We don't want people tripping over these cylinders and them falling to the floor, and then they become a bomb, a torpedo. If they end up busting the end of that off, it like this oxygen is ready to blow, and this becomes like a torpedo and can really hurt something or someone. We want to keep it away from a heater. And so wherever it's stored, you will see, especially in the hospital, I think maybe in long-term care facilities, they have like a separate room. But in the hospital, we have like straps to the wall, and that's how we secure them from out, like they're out of high traffic area and secured to the wall. So make sure they're away from electrical devices, because if in the event that something that's plugged in short circuits and causes a spark, we're going to cause a fire. And make sure you know where a fire extinguisher is in the event that we do cause a fire. So here we are again talking about oxygen therapy for clients with COPD. High carbon dioxide levels in the blood is normal stimulus to breathe. Clients with COPD may have a chronically high CO2 level. So stimulus to breathe is hypoxemia, low blood oxygen levels. So high flows of oxygen can potentially relieve this hypoxemia, removing the stimulus to breathe. Low flows maintain a slightly hypoxemia state, maintaining the respiratory drive. Clients who have COPD are receiving oxygen must be observed carefully for respiratory depression and arrest. So again, we want to be cautious on administering too much oxygen to our COPDers, because it will cause them hypoxemia and they won't have that stimulus to breathe properly. So here are some nursing diagnoses. So maybe you need to make a care plan, and here are some of our NANDA approved nursing diagnoses and our related to situations, our planning, and our implementation, and our goals and outcomes. And how are we going to educate our patient? It's important for them to educate on to take advantage of respiratory therapy places, accessing oxygen supplies like our Vital Air. People who cannot get off of oxygen in the hospital, we send an order over to Vital Air or Medical Air, or whatever they're called, and they come right to the hospital room and they do their assessment, and they get oxygen set up at home for them before they're actually discharged. We want to make sure that they know how to use the equipment that they have, how to turn that dial, make sure they set that regulator at the proper number, and obviously support the client and the family in any way that they need. So here is just some knowledge building nursing care plan around asthma. You can read through this and see if you want to challenge learning. And then, of course, we want to do proper documentation around what interventions we had to perform for our patient, how they responded to it, what you had to do. If you didn't chart it, you didn't do it. And now we jump into suctioning, respiratory suctioning. So the reason for suctioning comes from obstructed airways. So we can have a partial obstructed airway where we hear respiratory sounds of gurgling. And to put it simply, the gurgling sound, like maybe I like to explain it like if you were to turn a kettle on and when it's at its high boiling point, we can have that gurgling sound, and it's air being forced past secretions. So we hear it a lot in our palliative folks as they're passing away, but also our COPDers or people who are acutely ill, that they're not able to, they're so sick that they can't expectorate or get rid of the secretions that are building up. So we may also hear like a low-pitched snoring sound during inspiration. And that when they're breathing in, air passage is partially blocked, maybe by a foreign object, maybe there's some stenosis happening, maybe there's so much inflammation that we're hearing that when they breathe in, that snoring sound. But then in our extreme immediate attention, we have somebody with a complete obstructed airway. And this extreme inspiry effort that produces no chest movement. So they are completely blocked, that they cannot get any air passage in or out. And this is an emergency situation. So airway obstruction can occur anywhere along the respiratory tract. So remember, our respiratory tract starts right from our nose and mouth and go all the way down our lower thorax area, lower airway. So what are some causes of the upper airway obstruction? Maybe there's an allergic reaction. Maybe there's a foreign object in there, infection, trauma. Maybe in our lower airway, what kind of obstruction might occur? Again, maybe a foreign body, inflammation from our asthma, pneumonia, or COPDers, or maybe there's some infection. We had somebody come in with he was an elderly guy, and the family, like the nursing home, sent him in because of difficulty breathing and kept feeling like he had something stuck in his throat. And they failed to mention that this guy also lost his partial denture. And he had to get sent to the hospital and admitted to get, well, I guess he went to emergency. They did an x-ray, and here he had swallowed his partial denture and it was stuck in his throat. So he got admitted where he had to have an emergency endoscopy. They put the camera down there and grabbed that partial. They were able to return the partial back to him. So you're going to see really interesting situations that happen. So again, signs and symptoms of the obstruction is gurgly respirations, low-pitched snoring sound during inspiration, gurgly sounds maybe during expiration, dyspnea, obvious distress. Patient may put hands to throat, flail arms, or attempt to speak. And this is where we're into an emergency situation too as well, right? And then evidence of hypoxia, where when you do an assessment, You're seeing or feeling that rapid pulse. You're seeing the restlessness, the flaring nares trying to attempt to get air into them. And again, that substernal or intercostal indrawing and cyanosis. So, how do we treat it? Airway obstruction is an emergency that requires immediate intervention. So obviously we're going to treat the immediate intervention. Maybe we're calling a code, we're getting ICU in. Maybe they have to intubate that person right at the bedside, depending on what the obstruction is. But if the obstruction is due to excessive secretions in the upper airway, we need to help them. They must be cleared by oropharyngeal or nasopharyngeal suctioning. So the purpose of the suctioning is to remove secretions that obstruct the airway in order to facilitate ventilation, to obtain secretions for diagnostic purposes. Maybe the doctor really needs a sample of their secretions and they're not able to do those morning sputum spits, and we have to use the suction to help us. Or maybe to prevent infection that may result from accumulated secretions. So remember, secretions can carry microorganisms. Maybe they're going to cause some problems that end up causing an infection, further complications. So what is oropharyngeal suctioning? It's removal of secretions by suctioning the oral cavity and pharynx. And nasopharyngeal suctioning is removal of secretions from the nares and the pharynx. So naso, nose, oro, as in oral cavity. So here we can see some different catheters that we use when suctioning. We've got our tubing that will hook up to the wall where we have wall suctioning, and all you do is turn the dial and it automatically turns on suctioning for us. The top one, we can control how much suctioning, and we'll go through this in lab. It's better to visualize it and see how we use one of those ones in the top picture. And then also we've got the lower picture. So these are only introduced into the mouth, extending to the oropharynx. So oropharynx is the back of the mouth to the start of the pharynx, no further. And know that so people who are gaggers, this may stimulate a gag reflex. Be prepared that maybe you might make them vomit. And then here is our nasopharyngeal suction. And so as you can see, the nurse is inserting that tube, which is a lot flimsier than our oropharyngeal suction, into the nose to suck out mucus and thick secretions. So this is all the things that you will need to in order to properly suction somebody, and you need your collection reciprocal, and I'll show you the picture of that in a couple slides here. We need our suction catheters and the tubing, and a towel just for comfort measures and to help if it's going to be a messy situation. Either sterile or just normal saline or like water from the tap. And then it says sterile gloves, but we typically just use a clean technique. I guess it depends on if we're trying to get a sample. But yeah, typically we just use clean gloves when we're doing a suctioning. So suction units may be portable. as in you might have seen one in 158 Clinical in the dining room. They have portable suction machines there in the event that somebody chokes on their food. And then we also have wall-mounted suctions. There should be a reciprocal attached to it to collect what we're going to suck out. And then the pressure should be set according to manufacturer's instructions. So here is a picture. The yellow and blue thing is our portable suction. It's got the tubing there off to the side. And then there's that collections canister underneath that minty green color lid. So that's when you suction and you're suctioning out all the mucus or vomit or whatever it be. That's the container it's going into. And then the picture on the right, this is more of an emergency room setup. Our stuff on the ward is a little bit different, but you'll see the dial up there that you can set the suction to, and the canister and all the tubing. And this is all set up and ready to go in the event that they have an emergency situation that they need to, that they have quick access to. So we have different sizes of the catheters that we use. They're called French suction catheters. And so you can have anywhere from a number 5 to an 18. And the larger the number, the larger the lumen or the larger the tubing is. So obviously your number 5 might be what you use for children, babies, or depending on, I guess, if maybe they've had an injury to their nair or something. Yonker suctions, firm tube is about 1/2 inch diameter for suctioning larger particles in the mouth, such as vomitus or thick secretions. And again, we're going to go through this. Oh yeah, so here's our smaller size suction. So what kind of indications get us to wanting to suction somebody? We're going to hear some noisy respirations. We're going to see some cyanosis. Our folks are going to be restless and anxious because they can't get air in or out. And we're going to see an increase in heart rate and respiration rate because your body's trying to compensate. We're going to see a decrease in oxygen level. And often the client will tell you when they need to be suctioned, as they can tell when secretions are beginning to build up. And these guys are chronically, like these, usually like say our paraplegics come in, maybe our handicap folks that they come in with a family member or their support worker and they're really familiar with them. Maybe it's somebody with a cancer or something that is, knows or has a portable suction at home and knows when they need to have their suction. So this slide is pretty important. This is our or sorry, not this slide, the next slide. Okay, so caution needs to be taken when suctioning. Should only be performed when there is evidence that it is necessary. So what are the indications around needing to suction? Need to weigh the benefits of clearing secretions against the risk of complications. So are we going to cause more complications suctioning? Your decision will be based on the degree of distress of the patient, what the patient is exhibiting. So this slide is the important one, and this is our scope of practice for an LPN. We are only allowed to do oropharyngeal suctioning. So like I said, we're doing more of the oral cavity and just to the top of the pharynx, kind of where that gag reflex is. We are not allowed to go deeper than that. We're only allowed to suction for 15 seconds at a time. So when you insert that Yonker or the other suction apparatus, when you put it in, you're counting, and I always count out loud. 1, 2, 3, 4, 5. And so when you reach 15, you're pulling that suction out. You're going to wait 20 to 30-second intervals between suction episodes. And the total session time should be no more than 5 minutes maximum. We want to really encourage these guys with deep breathing and coughing between suction to loosen and expel the secretions. So maybe we have suctioned out what we can that's just kind of sitting at that oropharyngeal spot, but maybe suctioning has also kind of sucked at pulling up some of those secretions. So we want to try, and obviously if they're able to, we want to encourage them to do those kind of deep breathing and coughing to try and get those secretions out or up more so that maybe they kind of get to the point where we can suction. So, and the reason why we only suction for about 15 seconds is if you've ever been to the dentist and they give you the suction after they spray water in your mouth, and if you hold it there too long, you can feel the air sucking in through your nose and kind of sucking everything out of you, and you kind of cough and it kind of makes you lose your breath. That's the reason why. We're sucking oxygen out of them as well when we're using suction. So this is why we have rules. So then we're going to make sure after we do any kind of suction, we're doing a post-suctioning assessment. We're going to check the vitals after we do that suctioning. We're going to make sure has their SpO2 levels returned back to normal, or have we caused more problems? We want to look at the appearance of the suction secretions. Are we seeing coffee ground emesis in it? Are we seeing hemoptysis? Maybe have we traumatized some of the mucosal lining? Maybe is it green that maybe or purulent that we're seeing some infection? We're going to want to listen to the breath sounds. Are we hearing better breath sounds, or are we still hearing bad breath sounds that we know that we're going to have to do this again? We want to monitor the respiratory rate, rhythm, and depth. And we're going to want to watch the skin color. Have we maybe done too much suction that were causing more problems? Or maybe when we started out, they were cyanotic and they're getting better. And we want to look for presence of anxiety. Have we, after suctioning, caused more problems? Okay. So the complications involved, again, as I just said, maybe have we caused more hypoxia? Maybe we've done some tissue damage or trauma, inserting that suction. Maybe we did it too long. Maybe we've caused some infection from introducing that suction, and maybe before entering their mouth, it hit their bed sheets, or I don't know, some microorganisms got on it somehow. Maybe we cause what's called a vagal stimulation, which is irritation to the larynx or trachea, which can cause slowing of the pulse. We might cause some bronchospasms, which may cause the patient to cough uncontrollably. But also maybe we might cause some increased secretions due to mucosal membrane irritation, and then we're creating more of a problem with more secretions. So we're going to make sure when we're following up after looking after a patient that we've suctioned. We want to ensure patient comfort. We want to position to facilitate easier breathing. We want to perform good oral or nasal hygiene. Maybe they're getting so much secretions in their nose, like hard boogers or inflammation from high flow oxygen, that we need to help them out. Get some, it's called Seqirus, this mucousy or this clear ointment stuff that they can put up their nose to loosen all the hard boogers that accumulate in there. Or maybe we need to do some good oral care um, that we can, put some mouth swabs in and clean up some secretions that way. And then we want to make sure that we assess effectiveness of suctioning. We go back and we closely monitor our patient. Are we seeing changes in the symptoms that started out? Are they getting better or are they getting worse? So before starting suctioning, obviously we want to do some teaching. We remember that we learned about being in the hospital is stressful when they don't know what's going to happen to them. So giving them, educating them and letting them know what's going to happen before we do it. You can tell them that it's not going to be painful. Suctioning is going to help them breathe better. We'll only suction each time for 15 seconds and then give you some time to rest in between. And this is where I say I always count out loud for them. And then another good little tip is to tell them or teach them how, when you're suctioning, if they want you to stop, to get them to raise their hand to let you know that they need you to stop, instead of grabbing your hand and maybe that ends up yanking that suction apparatus against the side of their mouth, causing some trauma. So that's a good little tip to teach them about raising their hand. Let me know if you need me to stop. And then, of course, we're going to do our proper documentation, what procedure we did, the character and amount of secretions that were sucked out, how the patient tolerated it, and other pertinent information around